Hi friends, happy summer. It's Dr. Russ. It is a hot day here in Portland. It's 5th of July today. It's 90 degrees already at 1 o'clock. And I'm back to do volume 2 of Touching Base. Thanks for watching. The other one that I did for April, it wasn't gangbusters in terms of engagement, but I think like 1,400, 1,800, like a significant number of unique viewers watched that video. So I'm here, I'm going to do it again. And this is for May and June of 2024. As we'll talk about, I've been really busy. You may have noticed that I haven't uploaded a treatment video in some time. Partially that's because I've been dealing with some health stuff of my own, and also patients' health stuff has postponed and canceled sessions that we had on the schedule. So here we are. And let's just kind of kick it off with how am I doing? How is the business doing? And how am I doing personally? So here's our scale. Well, on the business side, we hit my 30,000th subscriber. I think that was in May. That's awesome. Thank you all for subscribing and watching. That makes me feel good. I did get several treatment videos posted. I had 12 new patients between May and June, 12 new patients. So an average of 6 a month, but I think it was pretty loaded into May. May was really busy. Fortunately, I had 2 disc cases reach resolution. I got to say goodbye to these folks. They were both cervical discs that had been irritated and were causing neck and arm pain. And they resolved without surgery and without cortisone injections, just rest, really gentle manual therapy, good supplements, and time. If you want to know my supplement protocol for disc healing, I'll link to it in the video description. And if for some reason I forget to do that, then ask me in the comments. If you're new to this, by the way, I'm Dr. Russ. Welcome to my channel. I'm a chiropractor. I practice in Portland. Thanks for watching. How have I been feeling clinically confident, with a 0 being I'm a complete idiot and a 10 is I can do no wrong? I've been feeling really good about that. Partly because of my own health stuff that I've been dealing with. I know it sounds weird, but like going to the doctor and being the patient and having that experience reminds me of how much I help people. It reminds me of that I'm a good listener and a good diagnostician, and it gives me that confidence. So even though I've been dealing with some of my own health stuff, I've been feeling really good in terms of my clinical confidence. On the energy scale, 0 to 10, 0 being totally burnt, 10 being super psyched. I'm about there. I'm like a straight line face that's yellow. Not amazing, but not terrible. I haven't missed any days of work, which is great. That's a good sign. But I think I'm on the upswing. More about that later. And then that intangible, that connectedness. Am I feeling connected to my practice? Am I feeling warm and welcoming? That's a 10. Or am I feeling tight and brittle? Feeling really good about that. I give myself a 9.6. It will be better when my body feels better. Until then, I've been a tiny, like, I don't think anyone would have noticed except for me, a little bit distracted. How's the business been doing? 0 is I quit because I'm broke, and a 10 is I quit because I'm rich. No, really. 0 is we're struggling, and a 10 is we're flush, we're feeling good with money, been doing really good. A 9 out of 10 is fantastic in that. We had, like I said, wrapping up a couple of disc cases. We also wrapped up a couple of motor vehicle cases, which was great. 12 new patients, feeling good. So the business has been good. We're making money. So what walked in this month? The first thought that I had that would be interesting was a dear patient of ours hurt herself with her foam roller. So yes, this is interesting, but also a cautionary tale. You can hurt yourself with a foam roller. So she's in good health. She has scoliosis. She's an adult with scoliosis. And sometimes her low back hurts her because of the curvature in her spine and the unequal weight distribution that happens. Muscles get fatigued and joints get a little bit overloaded. So she was using a ball, a foam ball, to release her left paraspinals. And by the time she saw me, she had been having pain for 5 weeks, which is a long time. If you just bruise it by going a little too deep, that's going to hurt, but it's going to hurt for a few days. It's not going to hurt for a few months. And it was also referring pain from the left ribs up into the shoulder. She was concerned, so she came to get my opinion. And so I asked her about these things. It did hurt to cough, and it did hurt to take a deep breath. It was getting better, but really, really slowly. 5 weeks is pretty slow. She didn't have any systemic illness at all. There were no cardiovascular symptoms. There were no GI symptoms. She doesn't have any chronic disease. Importantly, there was no tingling or numbness. Anytime there's referred pain, I want to know if there's tingling or numbness going along with that, because that's an indication that there's potential for neurological issue, usually entrapment, creating the pain along with numbness and tingling. And she had not had any x-ray. So, I was thinking about a fracture. That was my first thought. Ribs can be fractured and they take a long time to heal. And when they're fractured, it hurts to breathe or cough, but it doesn't otherwise affect you. It's also possible that there was no bone fracture, but just a strain, a soft tissue injury. Those can take a long time to heal. Those intercostal strains can take a long time to heal. But we still also want to be concerned about thoracic and abdominal viscera. Anytime there's pain in the body wall, it should be on your mind, heart, lung, and since it's the left side, stomach and spleen. But I felt, normal abdominal exam, absolutely no symptoms on the review of systems. So I thought these were probably the two most likely diagnoses. But without an x-ray machine in my office, I couldn't tell her for sure. But I did feel comfortable suggesting that we do some soft tissue work around the painful area and not work directly on it in case it was fractured. And I counseled her to be patient. Well, she came back 3 weeks later. She said she had had an x-ray and it was fractured. And that was 3 weeks ago, and she was better. But she had a new issue, which was that she was doing gyrotonics, which I love. I am not throwing shade on gyrotonics. I endorse it fully, but it was her first session, and I think they did a little too much because she woke up the next day with marked stiffness in her lower back. There weren't any disc signs. A straight leg raise, well leg raise was negative. She had no radiation or referral of pain. It was just in the lower back, right around L4 and thoracolumbar junction. So it was more like middle to upper lumbar. So we did what we do, which was had her comfortable and did myofascial work on her gluteals, her paraspinals. And I think we did that twice and she got better. And now she's traveling for the summer, which is awesome. The next thing that came in, this was interesting. I had only seen this once or twice before, which was an occipital headache that turned out to, I think, be occipital neuralgia. It was a warm spreading pain that was unilateral. It was happening once or twice a week, and he described it as debilitating. When this happens, it's debilitating. I can't work. I can't concentrate. It's extremely severe pain. He didn't have any visual changes, auditory changes. There was no vertigo. There was no dizziness, no problem with his balance. He didn't have any problem with speech and swallowing. Those are all cranial nerve signs. If those are present, none of them were. I went through and did the cranial nerve exam. Follow my finger, make faces, stick your tongue out, looking for blind spots. Everything was totally normal. And his neck exam was essentially normal. There was no obvious sign of injury. And doing a George's test to test for basilar artery insufficiency was also negative. So I felt like this is a green light to palpate and do some body work in there. He had marked tension in his neck, especially the right upper trap, which was right where the symptoms were coming from, and in the suboccipital area. So my working diagnosis is occipital neuralgia. So here's a picture of the side of the head, skin and fascia taken off, obviously, so we can see the muscles and the nerves. Fascinating. We're going to zoom in to this part here. So there's the external auditory meatus. There it is again. So here's the occiput. And right here, piercing this fascia, where the sternocleidomastoid, the upper trapezius, and the splenius meet, this nerve, artery, and vein pierce out to the skin. That's the greater occipital nerve. It is the dorsal branch of the spinal nerve that comes out between C1 and C2. So upper cervical mechanics can really affect this nerve. And it seemed pretty clear to me that it was a distinct possibility in this case. So here's the same spot from the back with pretty much everything taken out. There's our greater occipital nerve. And here it even shows you piercing the trapezius complex and coming out here between C1 and C2 and coming right under that obliquus capitis inferior. Really fascinating. So suboccipital biomechanical issues, trigger points, muscle tension. We've been seeing a lot of that. Can entrap nerves. And the warm, spreading, hot nature of that pain is what made me think nerve entrapment. Unfortunately, I never saw him again. He came in once. I did the exam, very gentle treatment, told him my diagnosis, and I haven't seen him. So maybe I was wrong, and he thought that guy's an idiot. I'm not going back. And maybe I was right, and he thought that doctor cured me in one session. I'm not going back. Maybe I'll find out one day. And if you're watching, probably not, but if you are, yeah, let me know. So another interesting case, not very uncommon. In fact, I thought it was interesting because it was common. It's something that if you're a body worker, you will see is complex chronic lower back pain. And this was a person who'd been dealing with this for many months and had tried lots of things and nothing was working. So here's the description of the pain. Left side, sacroiliac, gluteal, and lower lumbar. So stretching from like L4 to the trochanter on the left side. Always worse when she woke up in the morning, kind of loosen up throughout the day. It was kind of coming and going for many, many years based on her activities and things that she had done, injuries that she had. But 15 months ago, it just started hurting and it hasn't really stopped since. She's had MRI, she's had X-ray, she had a cortisone injection, she's had adjustments, she's had all sort of things. Nothing's really helped. And it also bugs her that her lower back makes clunking sounds. Can be very disconcerting, even if it's not painful. As in her case, it's not painful, just disconcerting. Significantly, there were no signs of radiculopathy. There was no pain going down the leg. There's no numbness, no tingling. It didn't hurt more with a cough, sneeze, or strain. Her discs look good on the MRI. The SI joint injection, as I said, they did cortisone, didn't help. Her traditional chiro rackham crack'em didn't help. And the massages weren't really that helpful either. So the first thing we need to do, even though there's no signs of radiculopathy, is rule out radiculopathy and neuropathy because of the chronicity of the issue. Those are the tissues that can take forever and ever to heal, discs and nerve roots. But motor reflex sensory exam, totally normal. Straight leg raise, well leg raise, normal. Valsalva was negative. So I thought, well, if it is a disc or radiculopathy, it sure isn't acting like one. So I don't think we need to treat it like one right now. Let's look at the mobility of the lower body. And she was so stuck in that left SI. The Gonstead listing is it would be EX ilium on the left with a slight AS component as well. But mostly that EX ilium and that overstretches those sacroiliac ligaments. They get really tired and irritated. And the sciatic nerve is right there. Of course, it can be irritated even without any radicular signs or symptoms. And that was where the pain was being generated. Her hip was basically not that affected. It had normal movement. Her lumbar vertebrae were hypermobile. I could feel them clunking as I put her through basic seated motion palpation. I wanted to know the strength of the core and the tone and pliability of all the muscles from the diaphragm to the knee. And what we found was she had weak hip flexors, quite weak on the left side. She was very tight and bound up in that iliac fossa. The iliacus, psoas, the deep lower abdominals, the internal, external, oblique, and transverse abdominal that are right there in front of the psoas. Her sartorius, adductor magnus, and IT band all really tight and really stuck, which I think is from prior chronic injury and overuse. And so those things can really get in that cycle of congestion, restriction, and adhesion, and it's really hard to break that on your own. What you need is mobilization, restoration of circulation, and reconditioning of tissues, and that's what we're doing. I was able to reproduce her pain by palpating the gluteal and piriformis region, but also could reproduce some of her lower back pain with direct palpation, gently, of the iliac fossa, the iliopsoas muscle. And the psoas and iliacus muscle can refer pain into the back, right over the SI joint. And I think that's partially what's going on here. And I think that's partially why her massages and adjustments weren't helping because those folks weren't getting into her iliac fossa. It's scary. It's sensitive. It's not far from the genitals. And a lot of people are just advised not to go in there when they go to massage school. And also the femoral nerve is there. Like if you don't know what you're doing, you could injure the nerve Your hand could slip and now you're touching their genitals. Like if you don't know what you're doing, don't do it. But I'm quite familiar and comfortable. So I got in there and we've been doing it twice a week, releasing and mobilizing the iliac fossa, the hip flexors, the medial thigh, the IT band. I'm not going to try to forcefully adjust that EX ilium. There's just too much loosey-goosiness in her lumbar spine. It wouldn't work. So what we got to try to do is recondition the tissues and retrain it to go back without force. Besides, she's already tried that and it didn't work. Home care focused on core strengthening, bridges, pelvic tilts, quadruped stabilization. I'll link to my core stabilization series video in the video description. And I really advised her, we had to get to her to do this gently and slowly. And folks with chronic pain, I get it. I've been there. You feel like you've got a way forward and you want to just like crash through that wall like the Kool-Aid man. But the way I think about it is like, yes, being strong, of course, is going to help you, but getting strong is what has to happen first. And that's really going to get you out of pain. So you can't just like pretend that you're strong and do these movements, even though it's hurting you. You have to do it a little more gently, incrementally, and slowly. And what happened was she had a great initial response. We loosened up the IT band and the sartorius and the adductor, and that really helped free up her lower back a lot. We added some exercises, those quadruped things and the bridges, and that caused her pain to increase again. And that baseline for her is like a constant 6. And we had sort of pretty, in a matter of 2 or 3 weeks, gotten it down to like a 2. Well, it went back again to her baseline 6. And so in talking with her, and we did a session where I just watched her do the exercises. It appeared to me like she was overexerting in the exercises, trying to complete, say, a full bridge. And her tissues just really aren't ready for that. So I said slower, smaller movements, and we'll build up to a full bridge over the course of 2 months, 3 months, I should say. I think she's 48, so quite healthy otherwise. So once she modified that approach and we kept going with the body work, because it was helping her, her pain decreased again. So we're still working. And I think she's really on the right road. She is back down to like a 2 or a 3, and hoping we can not only keep it there, but get it down to mostly 0. Once someone has had pain in an area for a few months, it's hard to get it all the way to 0. It might become an area that gives them a little problem here and there. That's okay. We can deal with that. If you've ever had chronic severe pain, you know what I'm talking about. If it's a little problem here and there, that's not really a problem. It's the things that dominate your life, as it was doing for her. This was interesting. I don't have too much to say about it. I just had never seen it before. This was an 83-year-old patient in really good health who was having lower back and leg pain and has got some pretty significant disc degeneration on his x-ray. He's also having neck and shoulder pain. So we did what we do. I did some gentle traction. I did some myofascial work. I did some non-thrust adjusting, and he'd feel better, and then he wouldn't feel better, and he'd feel better. I don't know. I think we did maybe 5 sessions, something like that. Well, he went to his PCP, who did a full workup and diagnosed him with polymyalgia rheumatica, which is a term that I heard in school, but I have never diagnosed it. I'm not exactly even sure what they saw in his blood work that gave them this impression, but they told him, don't bother with chiropractic. It's not going to help. Take prednisone. So he's taking prednisone for a year. They gave him a 1-year course of prednisone, and I hope it works. I hope that he feels better, and I hope the prednisone doesn't damage his adrenals. As I said before, we had a resolution of a couple of MVA cases. And so a question arises like, well, how do you know when they're done? Dr. Russ, how do you know? How do I know when to release, when to discharge someone? Because no one's ever perfect, right? Everyone always has stuff. Like we can pull 100 people in off the street, 98 of them will need an adjustment. So if they have full pain-free range of motion of the affected area upon exam. So if it's a neck injury, I won't let them go until either they have full pain-free range of motion, or they have had nearly full and slightly painful for long enough that I'm convinced that unfortunately it's probably not going to get much better. Full pain-free strength of prime movers and stabilizers of the region. And this one is so important, the ability to engage in their activities of daily living with minimal modification and either no pain or quickly self-resolving pain. So low back injury in a car accident, yes, it does happen. And, we treat for weeks and then they get better. And then they're gardening because it's summertime, it's gorgeous. And they say, yes, my low back is sore after I garden, but I take a hot shower, I stretch out, and I feel fine. In my book, that's not a problem, especially if you're over 40. So I want to know, is this pain interfering with your ability to sleep? Is it interfering with your ability to work? Is it interfering with your ability to do the things you like to do, your hobbies? Is it interfering with your ability to travel, especially in the summertime and around the holidays? That's a big one. People getting into car accidents and having injuries in late November and mid-June, it's the worst because they don't want to be laid up for the holiday or for their summer. But unfortunately, sometimes that happens to me too. Are you able to care for yourself and childcare? Like, are you in so much pain that you cannot bathe? Are you so impaired that you may not cook your own food or care for your children? And are you able to, this is kind of the icing on the cake, engage in the sports that you like? So I want these questions to have the positive answers that, yes, I feel better. And yes, I'm able to do all these things. That is a person who is definitely ready to be discharged. So finally, I will end with this last piece. Was that there is a lot of stress going around right now, and a lot of people really feeling it in their bodies, and myself included. So I alluded earlier to my own health stuff, so I'm going to lay it out for you. It's quite personal, but here it is. I have been having prostate problems. I'm 54 years old, and it's pretty unpleasant, really painful, and you feel like you have to pee all the time. And so I go in and I say I'm having dysuria and frequency. And so I'll do a UA, urinalysis, and it has been negative every time. And they say, well, if the infection is in your prostate gland, it probably won't show up in your urine. So they give me antibiotics. So good patient that I am, I take the antibiotics, and it's always been taking 3 weeks for this to clear up. This has happened 3 times in the last year and a half. 3-week episodes of dysuria, which is painful urination. This is my life. So I'm way better now because finally I got in to see a urologist. In the meantime, I had had UA, I had had blood tests, I had an ultrasound of my kidneys and bladder, keeping me busy, partially why I haven't been posting as much. And all of that was normal. I'm really healthy. My blood work, it's like a 35-year-old doing really, really good. Cholesterol's good. All that stuff is good. Blood sugar's good. I don't take any medication. So I thought, well, what's the urologist going to tell me? You know, by the time I was able to get an appointment, my symptoms had gone away, blah, blah, blah. Well, the whole thing came back and I took antibiotics again. And again, it didn't really work. And again, all my tests were normal. So I thought, okay, I got to talk to a urologist. So I went in and he was wonderful. He took his time. He listened. He didn't interrupt. He answered all of my questions. He reassured me, I'm not leaving this room until all of your questions are answered, and I'm going to let you message me if any more questions come up. Really, really helpful. And what he told me was that my prostate is normal. It is not swollen. It is not infected, which is wonderful news. But he said my pelvic floor is really tight. And so we talked about that, pelvic floor tension, which I was not aware of. But thinking back my whole life, again, if this is TMI, just fast forward. But this Dr. Russ, I've always been kind of a small bladder person. I just thought my family, we have small bladders. Well, according to my ultrasound, bladder is normal size. Turns out what I have is tension that I've been carrying in my pelvic floor for decades, potentially my whole life. So been there so long, I'm not even aware of it. So he brought this to my attention and referred me for pelvic PT, which I'm going to go to. And I started already working with my Pilates instructor, Lily. Hi, Lily. She's wonderful. She's got a few videos online too. I'll link you to her channel. And I just told her, this is what I'm dealing with. I see no point in not telling you that I'm having pelvic floor issues and we need to focus on this. So we're focusing on teaching me pelvic floor stretching and relaxation. And I've been doing that most days. Once I kind of have it down, I'm going to make a video and share with you what we do to loosen up and relax the pelvic floor. It's really, really important. But it's really caused me to think about how I deal with stress and what kind of resources I have at my disposal to help me deal with it differently and more productively. And that's my goal. So I don't know if you get this about me, Um, but I really like to be good at the things that I do. And I think that's a good quality about myself that has served me really well in my career and my relationships. But I do put a lot of pressure on myself. And I think that's partly how this shows up. So, um, all that to bring it back around to the things that we call psychosomatic, neuroemotional, mind body pain, or more recent term by Dr. Sarno, tension myositis, manifestations as real physical pain generated by anxiety, generated by worry, generated by suppressed anger, generated by all sorts of suppressed feelings. And so we have to be really careful when we're talking to folks, our patients, and to ourselves about this. It's not in your head. It's not make believe. You're not pretending. It's real physical pain from hypertonic type muscles, wherever they may be, that are causing muscle spasm, that are entrapping nerves, that are impeding local circulation, that is changing the way that your body moves and bears weight. It's real. But if you just do the body work, it's not going to get better. Body work is lovely. Of course, I love it, receiving and giving, and it helps relax people and it helps relieve pain. But if the generator of this issue is a thought pattern, just doing body work isn't going to change the thought pattern. And let me just say, there is no judgment. It's nobody's fault. We all have stress in our lives, and this is a stressful time. Like, it's a beautiful time. It's an amazing time, but also, my goodness, there's a lot going on and all this disinformation flying around. It's hard to know what to think. This is really stressing people out. I'm in the same boat, and it's showing up like this in almost everyone. So as I'm going through this process personally, of my own body and awareness and tension and how my mind is interacting with my pelvis, as weird as it may sound, I'm learning a lot and starting to see it more in my patients after 26 years. Like, not that I never thought of it before, but eyes opened in a new way, especially the pelvic floor. Mental, emotional stress leading to muscle tension, leading to pain for these physiological reasons. Decreased local circulation because blood can't percolate through a hypertonic muscle. These tight muscles entrapping nerves, decreasing the stability and mobility of your joints that are being crossed by these tight muscles. Also, on the brain level, in the central nervous system, you become hyper attuned. I saw this happening to me with my pelvic pain. Any little hint of pelvic pain, and I would start to spin out like, oh no, here we go again, another 3 weeks of this really distracting, difficult pain. That hyper awareness and instantly jumping into the catastrophic mode, that's actually, it's kind of a mind fuck, but that's really actually kind of diagnostic of this kind of a thing. And it's so not helpful to tell people, maybe you should pay attention to something else. Or maybe the problem is you're thinking about it too much. Like that, that's not helpful. What's helpful is to reassure people, explain what's happening to them so they understand. This is real pain that is caused by these muscles being tight because of your chronic stress. And this is a strategy your nervous system has adopted in order to adapt and cope. That's what we're all doing. So this is your strategy. And it was adaptive for a while, and now it's maladaptive. So when you feel this pain start to come up in your shoulder, in your neck, in your pelvis, what I want you to try to do is think, oh, this is me being stressed. And what I need to do is relax, and this pain will get better. Instead of, uh-oh, I'm going to jump on Google. Here's my symptoms again. What does this mean? I got to call my doctor. This is terrible. This is terrible. This is terrible. It's so easy to spin out, and it's going to happen. We are susceptible to that in our brains. We all are. So hyper-awareness is real. The other one is central sensitization. Neurological pathways get worn in just like a path through the forest. And just like you know how to tie your shoes without thinking about it because you've done it so many times, that's a neurological pathway that's been kind of ground into your nervous system wonderfully, but so can pain pathways. And that can be changed, but sometimes that central sensitization makes the problem worse because it just becomes easier for the person to feel pain from this part of their body instead of other sensations. And so again, not telling them it's in your head, you need to stop focusing on it. Give them other things to think about. Teach them stretches so that they can feel that part of their body opening up. You can see that's like my pelvic floor opening up. And then finally, changes in body chemistry, particularly stress hormones, can perpetuate and drive this, and that needs to be addressed as well, nutritionally or with activity, and of course, therapy and counseling. I'm a fan. If you find the right therapist, you can really, really get a lot of good work done and help yourself break these stressful cycles by recognizing when you're starting to slip into them. So here are the places that I find people really holding tension the most. And starting with me, the pelvic floor. And this can cause low back pain, hip pain, pelvic pain. So that's like deep in the pelvis, around the bladder, around the pubic bone, painful menstruation, painful periods, pain with sex, pain with urination, constipation. Sometimes this pelvic floor issue, it can get so tight that it makes it really hard for a person to pass stool. Fortunately, that's not me. And menstrual cramps or pelvic cramps, all that can just be caused by pelvic floor tension. So if you're listening to this and this is you or someone you love, and they have this pain somewhere in their body, and they've had x-rays and said, nope, x-rays are normal. They've had physical exam. They say, nope, physical exam is normal. Blood work, normal. Urinary, urine tests, normal. They might want to look into this as being potentially one of the causes of their situation is pain in the pelvic floor, or the other place is the diaphragm and the ribs. So all those intercostal muscles and the respiratory diaphragm, these are under our conscious control, but they are mostly monitored by subconscious. So we're not really even aware of how much tone or how we're using them, and they can get tight and stuck. And shoulder pain, mid-back pain, respiratory issues, especially asthma, difficulty with the airway, indigestion, shortness of breath, tingling in the arms and hands from entrapment of the brachial plexus, all from tension in the diaphragm and ribs, which just shows up as shallow breathing, and difficulty with rib mobility. Finally, the neck, not finally, but thirdly, the neck and shoulder junction. So right here where the upper traps meet the neck, shoulder pain, upper back pain, neck pain, headache, ringing in the ears, dizziness, vertigo, arm pain, and tingling also from entrapment of the brachial plexus. And finally, the cranial base. So these areas again, pelvic floor, diaphragm and ribs, where the neck meets the shoulders, and the cranial base, the occiput, the suboccipital muscles, that area can refer pain to the shoulder, into the neck, could give you headaches like our friend before with the occipital neuralgia. It can give you brain fog, visual changes, ringing in the ears, a lot of TMJ stuff, lots, almost all. I mean, yeah, people sometimes have malocclusion or arthritis in the joint or injury to the joint, but like 90% of the people that I see with jaw problems, it's chronic muscle tension in the neck, face, and head. And then, of course, I did a video a couple weeks ago about cranial work and how important it is and kind of how to do it a little bit, talking about how the pituitary gland sits on the sphenoid bone. And when there's cranial bone dysfunction, it affects the pituitary gland, which is the master gland of the body. And that has systemic effects on the whole body. So what do we do for ourselves as humans? And what do we do for our patients and clients? Well, number one, compassion. Do not dismiss, do not invalidate, compassion. And I handle this with care. If I suspect, and I often do, suspect that someone's issues are being caused or magnified by emotional stress in their life, I usually don't lead with that. They're there because they want some physical medicine, and that's what I'm going to do. And then while we're doing that, I can talk like, what's stressing you out lately? Have them take deep breaths, try and get some insight into their picture before I, try and superimpose my diagnosis onto their stuff. It's funny, the urologist said to me, after we're talking about pelvic floor tension and how it's affecting me and why it's there, because I'm a little bit of a stress case, he said, this is a good urologist. I like this guy. He said, I definitely want to keep an open mind, but often I can tell within 2 minutes of talking to somebody that they're dealing with pelvic floor dysfunction. And he's like, I had that feeling about you pretty quickly. And I was like, really, doctor? What makes you say that? And he described the way that I had come in with all of my information completely organized and in order and ready to share with him. I knew what was going to be relevant, and I made sure that I delivered that information succinctly, as you might imagine. And he's like, obviously there's nothing wrong with that. That's just a certain personality type. So I'm like, well, how, I don't understand. How else would I be? Am I supposed to walk in and like not be ready? So this is the core part of who I am. And, you know, if you're relating to me, bless you, drop it in the comments. Let's laugh at ourselves together. I wouldn't call myself anal, but maybe some people might. So anyway, handle with care, do the body work, for goodness sake. That's why they're there. Be gentle, work on those key areas. I do not recommend doing pelvic floor work unless you are specifically trained to do so. And in the near future, I will try to do a video on pelvic floor work, external approach. You want to be affirmative and encouraging. You will get better. You are okay. I understand this hurts. I understand you have this pain. We're going to figure it out. I'm going to encourage you. I want to like soothe them. I want to give them breath work. So I posted a breathwork video about a month ago or so. I love it. People have given me really good feedback on it. And I will do breathwork right there while my hands are on them, and I'll give it to them as homework. And basically in your relationship with the patient, you create a container, right? They're in the treatment room with you. It's private, it's confidential, it's secure. There's space and time for them to talk about what they want. You don't shut them down. You let them talk. You ask questions. You're genuinely curious. That's the container. It's so healing. And it does, from the business point of view, keeps people coming back because people like their containers. Thanks for watching. 35 minutes in. I really appreciate the ability to ramble a little bit and share some of my own personal story. I invite your comments as always. Thank you for watching, and I'll see you in the next video. This is Dr. Russ.